Dr. Mechtler. Thank you so much for joining us. Dr.
Sure.
Mechtler is the medical director of the Dent Institute, Dent Neurologic Institute, Dent Headache Center, and Cannabis Clinic. You're also the professor of neurology and oncology at SUNY Buffalo and the chief of Neuro-Oncology at Roswell Park Cancer Institute. And you're presenting at CannMed next week, and we're so excited about your presentation. I'm so glad we like to cover the intersection of cannabis medicine and social movements and politics. So we're really excited about your presentation, a comparative study on the use of medical cannabis in the Caucasian and African American populations.
Yes, it's
a little preview.
Yeah, I started this cannabis program when it was legalized. Medical marijuana was legalized in February of 2016 in New York State. And, I started off as a typical professor of neurology, rather skeptic, not knowledgeable, uneducated. But I was receiving 500 phone calls a day from patients. Just a little background, I'm the director of the largest neuroscience center in the country, where we see about 1,000 patients every day in this neurological institute. So as I was receiving phone calls, I said to my staff, you know what, we got to do something, because initially in New York State, 7 out of the 10 indications for medical marijuana was neurological in nature. Everything from MS to ALS to epilepsy to neuropathy to spinal cord injury, Huntington's disease, I could go on. And so we started a clinic at my institute, and I became the director of that. And since 2016, I have gathered over close to 10,000 patients who are actively in our program. And to my knowledge, it's probably the largest in the country. And not only am I seeing patients as their physician, not as somebody who certifies them, because there's a difference. We actually become the patient's physician and document 3-4 page notes, and then add the information about the use of medical marijuana when it comes to efficacy, dosing, ratios, what vehicle it's coming in, meaning is it a vape, is it a capsule, is it a tincture? And looking at the side effect profile, looking at efficacy rates, looking at standards of pain scales, and have all that documented in the patient's records, which is electronic records, which I can then pull out. So in the course of my, seeing patients, and we see about 110 patients a week, and I noticed that a lot of the African Americans are not coming back to see me. And, and I kind of looked the other way for about a year or two. Then I said to my staff, my research staff, I wanted you to pull a comparative study of African American use of medical marijuana with Caucasian. Now, unfortunately, Buffalo is a very segregated city. So by zip codes, I could figure out the level of pay and also the use of recreational marijuana and the use of medical marijuana and the efficacy rates. And I did a comparative study, which I like to present in California. But the bottom line is there's a huge discrepancy. And, over the last 50, 60 years, we know there's been a disproportionate racial influence on cannabis, either due to prosecution, persecution, and that has been due to the fact that we have racism in our institutions, in our judicial system, and the African Americans have been shortchanged all these years. And I won't get into the history, although in my lecture I may mention a little bit about why. But the bottom line is we thought that these medical programs, which is legal in 33 states in this country, is going to equal the playing field, allow individuals to use medical marijuana. And again, as I look at my numbers, there continues to be a racial discrepancy, and that needs to be addressed. And either the state or the federal government needs to subsidize what we're doing and equal the playing field for Caucasians and African Americans. Otherwise, we have a racial injustice when it comes to the use of these medical marijuana programs, which preferentially are being used by individuals, not because of race, but because of income.
Yeah.
So there's an income disparity. And I'm not going to call it racism, because the fact is that the income disparity in a segregated system does not allow African Americans to be able to afford the use of even medical marijuana, and are forced to use the cheaper model, which in my state is illegal, which is adult or recreational marijuana. So they may get certified, but they don't come back. In over 60% of my patients don't come back who are African Americans. Wow. Twice as much as what Caucasians are. So this is what my discussion is and what possibilities one can do. I'm basically bringing out statistics of my practice.
Right. Awesome. Well, I'm so glad that you're doing that work. I thank you so much for doing it, and for noticing, and for talking about it. So.
At the end of the day, as a physician, because I'm a practicing physician, at my age, you have to have a tremendous empathy to your patients. And when you see them suffering, and when you know there's a drug or a cannabinoid that actually improves their quality of life, and they're unable to do it, and have to go back into recreational smoking, which as an oncologist, you can imagine my opinion on smoking, period. It's a shame, because, it's like having anything. You have the tools, you just can't use them. So I'm hopefully that this will initiate a debate nationally and locally on how to bring a program that was initially felt to be beneficial for the population when it is not. That has to be corrected, and there's means to correct that, but that'll have to be done at a political and state level.
Absolutely. In Thailand, the state hospital is using confiscated cannabis that's been cleared, checked for pesticides and parquat, making it into oil and giving it away at the state hospitals. That's how Thailand is working it.
Yeah, I would say that would make a lot of sense, but I think you and I know that that's not going to happen in this country. It could, but I don't think it will. The states have to make decisions. I think the states have the power to make decisions on how to equal the playing field, and they're going to have to bring out their thinking caps. Either drive the cost of medical marijuana down, because every state that has approved recreational marijuana, the medical marijuana has taken a hit. And I'm not a believer that people who want medical marijuana want to get high.
Right.
I've been told this in dispensaries from California to Colorado, that people who want medical marijuana just want to get high. That is not true. And I say that because I have 10,000 patients, some of which are 103 years old. So I know for a fact that out of my 10,000 patients, less than 2% have euphoria, get buzzed. And I see a population of the 60 and above who have arthritis, who have irritable bowel syndrome, who have sleep disturbance, and they do not want to get high. They want to get better. So it's a quality of life issue. And we have an opportunity to improve the quality of life of our population, the population that may need it the most, the geriatric population, which is getting greater in numbers as we get older. So for that reason, something has to be done. Something has to be done at the state level and at the payer level too. I'm looking at working with payers to see what happens if a payer steps up and pays for 1 year's worth of cannabis, and look at the medical economics at 1 year. What happens at 12 months? Are the patients using less medication? Are the patients using less opioids? Are the patients going to ERs less often? So that type of science has to be done, because I promise you, based on my clinical experience and acumen, that patients are throwing away 2 or 4 or 5 medications, are coming off the opioids in today's world where we have an opioid epidemic with 130 patients dying every day. So we have to be very sensitive to the fact that there's a possibility to improve the medical economics. We just have to prove it, have to show it to the state, have to show it to the payers, And that's what I'm trying to do in New York State with Albany and payers in New York State to run a study with similar results. And we actually are right now sitting down with a specific payer.
That's really an incredible study that you're doing. I thank you so much for taking the time to do it with all the 10,000 patients that you have, to be able to also do that study. I know it's extra work, but you really are doing heroes work by helping move it forward.
You know who the real heroes are? First of all, the patients are the real heroes, because they've been suffering and they open up their minds, and they come to us with faith, and it's been working extremely well. You know, I'm as an oncologist, my research for years was brain cancer. You can imagine what I've seen over 30 years of treating patients with brain cancer.
Yeah.
So this is a new part of my life right now. But you know what I did in Albany, and I have to tell you, you know, you could be critical of state governments, but New York was rather receptive. Is that I brought in, it's not just me. I have a group of nurse practitioners and PAs who are certifying patients and seeing patients regularly. This is my group, and they're wonderful. And New York State has allowed NPs and PAs to see patients, because many states, there's not enough physicians to go around. And you can't find them because they're not on websites. So I asked Albany to look at it and allow nurse practitioners, PA, to certify patients after they take the appropriate, you know, regulatory examinations, and they are. So I wish I could tell you that 10,000 my patients, it's my group. So we have a large cannabis clinic, and you know, we're seeing 110 patients a week, and it's really has been endearing to us to see the response. But it's really a group effort. You know, I'm as a doctor, as usual, I take the credit.
What percentage are older patients in your clinic?
So the study I did, and you can cross-reference my name with Geriatric, was an interesting study that I presented at the American Academy of Neurology. And let me just say that the large international meetings that we have in neurology, and neurologists tend to be a relatively conservative group of individuals. They're not always open-minded, but for the first time in the history, we had a cannabis course where we had lecturers, and we had over 400 people attending, and I presented 6 abstracts, and that was in Philadelphia this year. Wow. And it was very successful. They invited me back for next year, and that meeting will be in Toronto. And so that's the American Academy of Neurology, and you can look at their website. So my research included a geriatric group, and it was a simple study. I just told my staff, look, take everybody over the age of 75. And then I found over 300 patients, 75 to, this was 2 years ago, so I probably have more patients, 75 to 102. That person now is 103. And look at them, and look at A, does it work? B, what are the side effects? And then grade the side effects, serious, non-serious, and so on. And I just did an abstract, presented it at the American Academy of Neurology. The media picked up on it from all over the world. It was everywhere from Europe to Australia, Israel, and the title was, not my title, was Cannabis Works in Grandma and Grandpa. And obviously that's an unprofessional media-based title, but the reality was these patients got 80% better. I just did serious side effects was basically, there was not one serious side effect. Some people didn't like the taste. Some people got dizzy a little bit. I changed the dose. But the reality is it worked, and the side effects were minimal. And then begs the question, well, if you're over 65, 70, and you have aches and pains, and to my knowledge, as I'm getting older, I'm feeling aches and pains, that what population over the age of 65 does not benefit from medical marijuana? Because they don't want to get high, they want to feel better. Right. And one day I foresee, as you're taking your vitamin C and your vitamin D, that you'll be taking your vitamin cannabis, because it makes you feel better. What 75-year-old doesn't sleep well? What 75-year-old doesn't have joint pain? Yeah. What 75 doesn't have anxiety related to the fact that they're getting older and they have that fear? So if you have a medication that's anxiolytic, anti-inflammatory, analgesic, and helps you sleep. 4 attributes. That's what I call a wonder drug. And then you look at side effects. So right now I'm looking at side effects when it comes to use of cannabinoids, when it comes to blood thinners. I think that's very important because if you're over the age of 65, let's be fair, most people either take aspirin, Flavic, or blood thinners. So I'm looking at studies to see if there's an interaction. And that's very important to do because there is a fear out there that it's going to interact with my drug. So these are the things that need to be done. And a lot of people are thinking about it. It just has to be done.
Awesome. I'm so glad you're looking at that side effect profile. It is no wonder that Big Pharma is not excited about cannabis. It seems like it affect their bottom line.
Yeah, I think the forces against the movement is twofold. One is the medical establishment. 9% of medical schools teach the curriculum of the endocannabinoid deficiency syndrome.
How do we get that changed?
Exactly what we're doing. I'm a professor at the university. I teach at the university. I teach at many universities, internationally and nationally. The word has to get out. You know, they don't have a choice. When you have 33 states that have approved medical marijuana, and that's over 70% of the population of this country.
Yeah.
You really don't have a choice. It's going to happen. It has to happen. For that to happen, you need science. You need good science. Yes, you need randomized studies. I have to tell you, I think a wonderful article in use of cannabinoids in the treatment of chronic migraine, which is one of the most disabling disorders in the world, according to the World Health Organization.
Yeah.
And I wrote the article. I think it's a tremendous benefit to the science of headaches and cannabinoids. And you won't believe the resistance I have. I'm publishing that article.
Wow.
I mean, I'm known in those circles. I'm not somebody who's naive. They know my name. And I have journals refusing to publish it. I'm on number 5 right now.
Wow.
And I haven't lost hope, and I won't, because that's, you know, we have to pursue justice, because it has to be published, and then people have to read it, and then it came out. They should have their own opinion after reading the article.
Right.
But to not to publish it would be a crying shame, and we're not going to allow that. So this is the resistance I find with the establishment.
Yeah.
Now, the pharma is a different issue. I mean, look, at the end of the day, pharma's reputation is getting nailed and killed on opioids right now. I don't think they want to take up the fight to be against medical marijuana. They do it in indirect ways. But, you know, look, this could be done outside of pharma, but it has to be done properly. It has to be done in academic centers. It has to be done with good research trials. It has to be published in reputable journals. And that's my focus right now.
Yeah.
And there's a lot of good people around the country who are trying the same thing.
Sure.
You know, it begs the question, how should research be done at a national level? Unfortunately, you're already aware that Schedule I licensing is difficult to have, and when you do have it, is that research going to be compatible with the real-life medical marijuana? And the answer is no. And the people who are doing Schedule I research in cannabis, who are utilizing cannabis from facilities that are outdated, is just not appropriate. So state legislation has to open up research for cannabis of quality that should be within that state and should be allowed in facilities and institutes with exceptions to the Schedule I license to do prospective randomized studies. Once we have that, then you'll have research in every state, but it has to be done. And for that, we need the support of the community, support of our politicians.
Yeah.
And to change some legislation within the state.
Of course, the easiest thing would be if 45 takes it off the Schedule I of drugs, which could happen in this political climate. He does need
you never know. I hope you're right. I hope you're a visionary.
Take this in however we can get it, from 45, 46, whatever. I'll take it.
Yeah. Take the handcuffs off me. Let me go.
Absolutely.
That would, once I have that as a Schedule 2 drug, or a Schedule 3, or it should be even more, as you know, Epidiolex is Schedule 5.
Right.
Once we have that, I think things will move quite fast.
Definitely.
You know what? Why shouldn't we be the pioneers of medical marijuana in the world?
100%.
Why wait for other countries to start doing their research?
Well,
Because,
Israel
you know,
is definitely the pioneer, right?
I mean, we've been pioneers in everything else. We should be here. And at your meeting, one of the reasons I'm attending your meeting is the excitement of meeting Raphael Mechoulam, who really is the grandfather of cannabis research. I'm looking, I've never met him, but you have other individuals of high quality at your meeting, Ethan Russo, for example. So I'm excited to meet my colleagues and learn from them and bounce things off them in regard to research going forward. So again, one of the reasons I'm flying for a few days over to California from beautiful Buffalo, New York, where the weather is sunny and there's no snow, which is a blessing. So.
I have one more question. I know you have such a wide variety of patients in your clinic. Tell me about your work with people living with dementia and their use of cannabis.
So, you know, the one thing we have to watch out for as professionals, as physicians, is that cannabis in general is not a panacea for the treatment of diseases per se. If you believe in the endocannabinoid system, there may be a deficiency in a lot of human beings with a lot of medical disorders, and the adjustment of that by the use of phytocannabinoids or plants makes sense. But to come out and say we have, despite the fact that CBD and THC, but especially CBD, is an antioxidant, neuroprotective, decreased glutamate levels, which helps with head trauma, all that is science. It makes sense. But unfortunately, we can't come out, and this is where companies get into trouble because they make statements. I'm going to cure your cancer. I'm going to cure Alzheimer's. So we use it in our dementia patients for sundowning, which is the agitation that occurs at nights, the anxiety during the day. I don't think CBD causes any detriment to my dementia patients. I just can't stand here and say that THC, CBD, or the combination is a way to cure Alzheimer's disease, because that science is not there.
Sure.
And even though, you know, I think
symptoms.
That's correct.
Yeah.
And those symptoms are real. Sleep disturbance, agitation, psychosis, depression. Now get to pain. As you know, pain fuels sleep disturbance. Pain fuels cognitive changes. So I think by treating their symptoms, do I see these patients improve? Unequivocally. We have a dementia center here, and I can tell you our patients use either CBD products, hemp-based, or medical marijuana, which is THC-CBD ratios. And I tend to use higher CBD ratios for those populations, but we adjust accordingly. So you know, I think, look, I mentioned to you, I can see anyone over the age of 65. As you may know, 50% of patients over the age of 80 have cognitive dementia of some sort.
Yeah. So
I can see patients using a neuroprotective agent as they've used vitamin E for the treatment of Parkinson's for decades.
Yeah.
So I can see right next to that a CBD product.
Yeah.
I don't see why not.
Yeah. Have you
found... let the long-term studies over not 1 year, but 10 years, 20 years, let the long-term studies define the use of cannabinoids as a neuroprotective agent in diseases such as dementia or ALS or Parkinson's disease.
Yeah, you know, like the patent says, you know.
Yeah, well, somebody beat us to that.
Yeah, the U.S. Department of Health.
Yeah, I was just a little bit late for that one.
Yeah, well, you know, let's all use it more often, right? So, cool.
Yeah, so you know, I really think that the hemp-based, I mean, not many people have talked about the Farm Act of 2018 that was signed in December it's kind of,
Call it the hemp
well,
pill.
but it's still a CBD product. It's still a CBD product, and it has efficacy.
Yeah.
You know, it may be not, you may be the person that said you need to have THC with the CBD. I'm not going to argue that point. But there's some diseases you want really a CBD product.
Sure.
For example, CBD in itself, high dosages, is the drug of choice for epilepsy and schizophrenia.
Sure.
But those dosages are really much higher. So I would not, you know, I embrace CBD products and embrace the hemp-based CBD products. I do believe that the full spectrum is the direction we should be going to, not just cannabinoids, but also including flavonoids and especially terpenes. But that's a different discussion.
Yeah. Well, I think that this emergence of hemp and cannabis medicine is going to help all of us look at plants in general more closely. Even maybe doctors are going to start learning about food. I don't know. It's a wild time.
Well, functional medicine is a new field of medicine. People are very excited about it. And I recently came back from Amsterdam on a brain-gut axis relationship.
Yes.
And I was there for 3 days in Amsterdam listening to everybody talk about probiotics and other ways to treat the depression, anxiety, dementia by treating the gut. And I stood up at the end. I remember distinctly stood up at the end and said, I thought this was a wonderful conference. 3 days, people talking about the brain gut, but nobody mentioned cannabinoids.
Yeah.
And I would like to see this in your next year's meeting. Yeah. And so it's interesting. This is in Europe, but the cannabinoids affect the gut, affect the brain. So I think that's a topic of functional medicine where use of different nutritional supplements, probiotics, and cannabinoids may be efficacious. I'll tell you a lot. 76% of my patients come in here for some form of pain. And often I ask them when they come back, they download the data in the computer, and I ask them, so you're better? I said, yeah, I'm doing much better. I decreased my opioids by 50%. I'm less constipated, and so on. But I'll have to tell you, it's helped my irritable bowel syndrome immensely. And it's helped my GI symptoms immensely. So it's like an indirect, I wasn't focused on that. I was focused on the pain. But it's interesting how these cannabinoids really help gastrointestinal symptoms.
Sure. I think part of the reason why they help people living with dementia who aren't necessarily able to articulate all of their symptoms is because cannabis works so well on so many different things that you may or may not know that you're having a problem with. I
won't argue that point. I think there's a truth behind that. And you know, anybody I see, I think I sprinkle a little cannabinoid on them.
Good. That's great. Awesome, Dr. Mechtler. Thank you so much. This has been such an illuminating conversation. I really appreciate you taking the time with us.
My pleasure.
There's a poster presenter at CannMed that is going to be talking about the gut-brain cannabis connection. So I'm sure I'll see you there. And I look forward to connecting in person.
Are you going to be there?
I absolutely am. I'm going to be there both days, and we'll see you there.
Looking forward to see everyone. Thank you very much.
Awesome. Thank you so much, Dr. Mechtler. Have a great day.
Have it. Same to you. Bye-bye.
Dr. Laszlo Mechtler, MD, Medical Director of Dent Neurologic Institute and presenter at CannMed. Great interview, Chel.
Thanks, babe.
Nicely done.
I'm impressed I was able to record it. And I was really stoked that I was able to switch it to the 2-shot there, because originally I was having technical difficulties, but I persevered, I persisted, and it worked out.
You did. It
Thanks
was great.
to you.
Well done, and now you know how to do Zoom interviews. Your media technology is expanding.
Yes, it's true.
But the content was absolutely great. Please, guys, share this show. Thumbs up before we sign off. We are going to sign off right now, guys. We're going to say goodnight to you all. The afterburn is not the same burn, but we're still going to be burning. We're headed to the CannMed 2019, reception in Pasadena. We've got invites, so we're going and we're going to check in. Maybe we'll see Dr. Mechtler. Maybe we'll see Dr. Meshalom. Maybe we'll see Dr. Barry, Dr. Mike. Oh, only prestigious, great doctors, big doctors, many doctors on Reefer Revolution
All the
Live.
doctors.
All the doctors.
All the smart doctors.
And it's just the beginning this week of many events. But we are heading out right now, guys, to the CannMed 2019 reception. We will check in. Make sure you subscribe. Get notifications for when we do go live, because we are going to go live. And wherever you're at, do what you do. And we'll see you later on tonight, and definitely next week at 4:20 on Sunday for Reefer Revolution Live, where we spark up, talk about marijuana in the mainstream media, the politics of pot, and cannabis care. We'll see you next time. Free the plant, free the people. Pot for peace.
Ciao.
Murderers keep murdering, the churches keep a-burning, the rapists keep a-raping, and the tide ain't turning. Uncle Sam, for all your power, things get worse every hour. It seems to me your energy's all wasted, chasing my friends and me. Uncle Sam, leave us pot smokers alone. Uncle Sam, leave us pot smokers alone. The terrorists keep terrorizing, our leaders keep a-lying, the haters keep a-hating, and the planet's dying. Do what's proper, call off your dogs and your helicopters. The problems of society were not caused by my friends and me. So hey, Uncle Sam, hey there, Uncle Sam, leave us pot smokers alone. Uncle Sam, leave us pot smokers alone. How many innocent people gonna be imprisoned? We just peace and love and street pop and brotherhood freaks. A touch of Mother Nature never made nobody violent, never made nobody hate, nobody will break nobody's peace. It's never been shown to be harmful. Don't you tell me no lies with your caffeine, codeine, nicotine eyes. The cannabis man is just recent, just since 1938 to relegalize it, realize it. You made a big mistake. Hey, Uncle Sam, hey there, Uncle Sam, leave us pot smokers alone. Uncle Sam, leave us pot smokers alone. Uncle Sam, leave us pot smokers alone. Leave us pot smokers alone. Uncle Sam, understand I love you, but leave me alone. Smokers alone. Leave us pot smokers alone. Our leaders keep alive.
This drug is dangerous. You cannot play with it. It's not funny. It's not something to laugh about. Good people don't smoke marijuana.
Yes, I'm all in. This is the time to go all in on cannabis.
Nobody who got in prison for marijuana, for example, immediately upon being released, they shouldn't be in there for that should be a misdemeanor. They should be out and their record should be expunged.
You can argue the pluses and minuses of marijuana, but marijuana ain't heroin. So we have to end that, and that's what I will do. As President of the United States, I believe we can do that through executive order, and I will do that.
Smoke weed every day.
But I want to express
Don't speak. Don't.
Just a few things that I want to tell you. When we first met,
no,
I was
don't speak. Please don't speak. Please don't speak. No, 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 go. Go, gentle Scorpio, go. Your Pisces wishes you every happy return.
Just one.
Don't speak.